Why are older adults more vulnerable to this process? Some of it may be self-evident, but we know that there are iatrogenic complications. That's why Medicare, for example, created the so-called never events, where hospitals are not paid or they're penalized for things like catheter-associated infections, falls with hip fracture, or injury in the hospital. If they meet a certain threshold, they actually are penalized for those accumulated incidences in the hospital. The other problem with older adults and their vulnerability is that they have multiple chronic conditions. It's broken down into 3 criteria. One criteria has 1 or 2 chronic conditions. The second criteria of older adults has 3 to 5 multiple chronic conditions. And the third criteria has 5 or more chronic conditions. You can imagine with those multiple chronic conditions that there's complex therapeutic regimens. And if you have 10 or more medications, there's a 100% chance that you're going to have a drug interaction. In that instance, we also have to deal with a functional decline. I call it getting your legs back, but an ability to transfer from bed to chair or from bed to standing could be quite an issue. It has been noted that patients who were transferred from the hospital to the nursing home setting could barely lift 2 pounds of weight in their arms. The other complications are delirium and dementia. If you have unresolved delirium from the hospital setting, there's a high mortality rate 1 year after discharge. There's about a 50% mortality rate in older adults that have unresolved delirium upon discharge from the hospital. Also, consider the adverse drug events. A lot of times, these medications are new, and these delayed reactions, for example, might not occur for weeks to months after the medication started. Such examples include statins that may cause myositis or myalgias, and you may not see that for several weeks to months until after the start of the medication. Poor social support may be obvious, but a lot of times we attribute higher capacity for older adults to take care of themselves and their self-care than they actually can. Be very cautious of the older adult who has a higher education. A lot of times college-educated older adults may give you the impression that they have more self-care capabilities than they actually do, or they just may have this inclination or predisposition that they don't want to bother family members and they want to stay independent. Don't lack the judgment to see that they really do need assistance. Finally, some people call malnutrition the 5th geriatric M of what matters: medications, mobility, and mentation. Malnutrition will affect about 15% of the population, and probably a little bit more percentage-wise of the recently discharged patients from the hospital. Studies have shown that hospitalization is associated with a starvation diet. There are just not enough calories that are included in a regular hospital diet, and it turns out that older adults need more protein than middle-aged patients, and that's often overlooked. Contributing to suboptimal transfers includes patient issues. As we saw in our initial case where the gentleman that needed wound care and was diabetic just wanted to go home, it was just matter of fact, and he didn't want to have anything else to do with it other than he was going home, and was very fixated on that. Indeed, people are fixated on never wanting to go to a nursing home. You really deal with a wide variety of attitudes about long-term care, some of them justified, and others maybe not so much. There's also system issues that we need to address, which we will discuss more on, in addition to talking about patient-specific issues that can cause a suboptimal transfer. Some of the risk factors for these suboptimal transitions, particularly from the hospital, include advanced age, socioeconomic considerations. If they already have a functional impairment, is going to be a contributing factor to suboptimal transitions if they are not real good at self-management or their chronic diseases. For example, with congestive heart failure, if they're not able to weigh themselves daily, that's going to really limit their ability to modulate. For instance, increase use of diuretics to get rid of increased water weight. The living alone is a big risk factor. They're like the Lone Ranger. A lot of times, these folks just don't have the social support to really optimize their recovery at home. Sometimes the transition to home care services is delayed. It doesn't occur as quickly as you would hope, and for a variety of reasons that could pose a problem. If you do order home care services, you need to indicate to the home care agency how soon you want the patient to be seen. Prior hospitalizations and long lengths of stay are also future risk factors for both poor transitions and for future hospitalizations. We often say that the prior hospitalized patient, if rehospitalized, sometimes become multi-visit patients. We all know and have experienced patients like that who just keep going through, like the turnstile, back and forth to the hospital, without necessarily getting much better. In contrast, the system-level risk factors for poor transitions include things like a hospital admission rate. If there's no good or poor discharge education, maybe not enough time, let alone the quality of the education, may be a predisposing factor. There certainly is insufficient communication across care settings. Oftentimes, we find hospitalists will do a discharge summary. Perhaps they do it in a timely fashion, and they've got the job done right, so they don't call the primary care physician. That would be desirable. That would be a higher level of communication, particularly if they contact the primary care physician in the nursing home setting, for example, where certain issues may come up. A lot of times, older adults will experience delirium. Up to 33% of older adults may experience some form of hypo or hyperactive delirium, and it's never documented in the medical record. It's important to know whether they had delirium, because if somebody is discharged from the hospital on Risperdal or Haldol, you can kind of presume that they had delirium, but who knows? Maybe they were put on an anticholinergic for depression in the past. So there's lots of what-ifs that are associated with transitional care and should not be left to make someone take an educated guess on that. Good communications are important across settings. Some of the barriers that we need to consider are diversity of patient needs. A lot of these are based upon social determinants of health or economic resources. Somebody that is in a wealthier category might be able to afford 24/7 nursing care that may not support well. 24/7 nursing care is not supported by Medicare and not many insurance companies, unless you have concierge service or something of that nature. We recognize the communication barriers when there's a delay in the discharge summary process. That has improved since the electronic medical record implementation. A lot of times, the hospitalist's knowledge of transitions of care may be somewhat sparse, and it's with that mentality putting the fire out and get him out, or quick transitions of care. Hospitals are put under a lot of duress precisely because of that reason. The hospital is at 110% capacity, and they have to go through high output. The other problem is getting a hold of the primary care provider. A lot of patients have a physician attributed to their clinical care, but in a lot of the cases, that particular physician has either left the healthcare system or is not seeing the patient anymore. They were transferred to somebody else, and that's not reflected in the electronic medical record. So, that's a problem. What is effective transitional care? There's a timeliness to it. It's important to align the care with what matters to the older adult within the context of their decisional-making capacity. We have to remember our illustrated case in point where the older adult was not able to handle himself in the home setting. The bottom line is that you apply the geriatric 4M of aligning what matters to the patient with their care plan, medication review, their mobility plan, plan of care and mentation status. Are they leaving the hospital depressed, cognitively impaired, or still delirious? It is not good to discharge a patient from the hospital because in the morning, they were just fine. By the afternoon, they could be confused with a loss of attention span and back in their delirious state. That's classic delirium. It ebbs and flows like a roller coaster. There will be moments of lucidity, followed by moments of a confusional state. What works well in transitional care? This includes good education. We want self-efficacy and self-management plans for the older adult. This is huge. Caregiver training shows huge impact, particularly in the cognitively impaired older adult. There should be some form of caregiver training, whether that be online or through diligent efforts to get the caregiver, either as a post-hospital healthcare coach or other techniques. It will have a high impact with a low cost. In terms of care coordination, it's important to have within the healthcare system the individual being routed to either specialty care or primary care. If you have a geriatrics program, to include in that process of transition to the geriatrics team, because there's really strong evidence that geriatric care involvement at both ends of the care spectrum, during hospitalization and post-hospitalization, really has a strong impact on improving quality outcomes.